I want you to imagine a scenario for a second. You are at a social event.
Right.
Maybe it's a dinner party with old friends or, I don't know, a professional networking mixer, or even just a casual weekend barbecue with your family.
Just a normal day.
Yeah, exactly. And you look perfectly healthy to everyone there. I mean, you've put on a nice outfit, you're holding a drink, you're smiling.
Nodding along to a story someone across the table is telling.
Right, you're being attentive. But inside your body, there is this invisible fire alarm. And it is just blaring at full, ear-shattering volume.
It's deafening.
Completely deafening, and it is relentless. Like, it doesn't pause when someone tells a joke, and it definitely doesn't quiet down when you try to focus on the conversation.
No, it doesn't.
And the most isolating, just agonizing part of this entire experience is that no one else in the room can hear it.
Yeah.
You are standing right in the middle of a burning building, basically, desperately trying to maintain your composure while everyone around you is just commenting on, what a calm, sunny day it is.
That profound disconnect between the internal biological reality of suffering and, well, the external perception of wellness.
Yeah.
That is the defining feature of chronic pain.
Yeah.
I mean, it requires just a monumental output of energy simply to exist in a space where your internal signals are entirely at odds with your environment.
And that invisible fire alarm, it's not a metaphor for millions of people. It's a daily, relentless biological reality.
Absolutely.
We call it chronic pain, but as the research in our deep dive today shows, that term barely even scratches the surface of what is actually happening to the human body. And the human mind, for that matter.
Right, because if we look at the International Association for the Study of Pain, the IASP, they provide this foundational definition.
Which is what, exactly?
So they define pain as an unpleasant sensory and emotional experience associated with, or resembling that associated with, actual or potential tissue damage.
Okay, actual or potential tissue damage?
Right. But our sources are very careful to distinguish chronic pain from that baseline definition.
Because of the timeline,
Yeah,
right.
Exactly. Chronic pain is defined as pain that persists longer than the normal healing time, which typically means crossing a threshold of about 3 months.
3 months. So why is that specific time frame so critical?
Because it represents a biological crossing of the Rubicon, essentially.
Yeah.
I mean, after a broken bone has knitted back together or a surgical incision has closed up.
Like the structural damage is theoretically repaired.
Yes. The soft tissue trauma has resolved, but the pain remains. We have to undergo this fundamental paradigm shift in how we view it.
Because in acute scenarios, pain is just a symptom.
Right. It's purely a symptom. It is a highly effective, evolutionarily conserved warning mechanism. It tells you to pull your hand away from a fire.
Right. The fire alarm is actually warning you about a real fire.
Exactly. But when we transition into the realm of chronic pain, it ceases to be a symptom of an underlying disease.
Oh, wow.
The pain loses its evolutionary value as a warning signal and transforms into a standalone pathological state. Basically, the pain itself becomes the disease.
The pain becomes the disease. That's heavy. And whether you are the one silently suffering through this, or maybe you're a caregiver, or you're simply a friend, trying to understand why someone you love keeps canceling plans at the very last minute.
Which happens constantly.
Constantly. Understanding this shift is so vital because the daily grinding reality of this condition manifests in what the literature calls the looking fine paradox.
Yes, the looking fine paradox.
Which is a core component of living with an invisible disability. I mean, the defining feature of an invisible disability is the absence of, visual shorthand.
Right, you don't have a fiberglass cast on your arm.
Exactly. You don't necessarily use a wheelchair or have visible bleeding or a rash. There's no outward sign of systemic failure.
And because of that absence, patients just run headfirst into a wall of daily ableist experiences.
Well, comments, right.
The comments are relentless. They're constantly met with variations of, but you look fine.
Mm-hmm.
Or you are entirely too young to be dealing with back pain.
Right, pain has an age limit. It's so invalidating.
It is, and that invalidation is systemic.
Yeah.
I mean, we operate within a society, and more specifically within a medical paradigm, that is fundamentally anchored in objective visual proof.
Like scans and blood work.
Exactly. Modern medicine is built on imaging and lab results. If a clinician can pull up an X-ray, point to a jagged white line on a femur and say, there is the fracture, it provides this clean, binary understanding of the problem.
Right. Everyone feels comfortable because the suffering is validated by empirical evidence.
Yes, the doctor sees it, the patient sees it, the family sees it.
Yeah.
But chronic pain, it operates in deep diagnostic muddy waters.
Muddy waters is a good way to put it.
For many patients, there is no MRI, there's no CT scan, and no blood panel that can adequately capture the sheer magnitude of their suffering.
Which is terrifying.
It is. And human nature kind of dictates that when society cannot see the wound, it implicitly doubts the experience.
Right.
The absence of visual evidence is frequently and tragically misinterpreted as the absence of disease.
And that pervasive doubt, it forces patients into this highly defensive posture, right? It leads to what the sources call a coping mechanism of concealment.
Concealment, yes.
There's a specific quote from the qualitative research we reviewed that just distills this perfectly. A patient stated, quote, "If it ever really hurts, I try not to let them know."
It's heartbreaking.
It really highlights a devastating social reality. Patients are literally forced to become actors. They are staging a daily, continuous social performance of wellness.
Just to avoid the exhausting burden of having to prove their pain to skeptics.
Yeah. And the socioeconomic burden hidden behind that daily performance is, frankly, staggering.
Oh, the macro-level data is wild. The cost of chronic pain is not just a personal tragedy. I mean, it is a massive economic drain.
Right.
In the United States alone, the annual cost of chronic pain is estimated to be between $560 and $635 billion.
Wait, billion. $500 billion.
Half a trillion. And that figure factors in direct medical expenses, like the cost of pharmaceuticals, hospital visits, but also the profound loss of productivity and the costs associated with long-term disability.
When you look at that $560 to $635 billion figure, it completely reframes the scale of the crisis. I mean, that exceeds the economic burden of heavily publicized public health crises, right?
Absolutely. It exceeds cardiovascular disease, diabetes, obesity. It is a hidden epidemic hiding in plain sight.
And the global data backs this up, too. The sources provide a detailed look at the socioeconomic cost of chronic pain in Sweden, which totaled an estimated 87.5 billion Swedish krona in a single year.
Right, but the breakdown of that number is where we see the true nature of the disease.
Right, because the direct care costs?
Yeah, the direct care-related costs, so the actual medical interventions, the doctor's appointments, the physical therapy, that only counted for 7.5 billion krona.
Okay, so out of 87.5 billion, only 7.5 billion is direct medical care.
Exactly. The remaining 80 billion krona came entirely from indirect costs, which is primarily this massive loss of production due to sick leave, presenteeism, and early exit from the workforce.
So the bulk of the economic devastation isn't the cost of treating the illness.
No, it's the sheer human inability to participate in society. It represents just millions of hours of human potential lost to people sitting in dark rooms, unable to function.
That vast chasm between the direct medical cost and the indirect societal cost, it perfectly illustrates the hidden nature of this condition. And to conceptualize the sheer exhaustion of the social performance we were talking about, I keep coming back to a technological analogy.
Let's hear it.
Okay, so living with chronic pain is essentially like operating a smartphone with a severely degraded battery.
I like this.
Right, so your internal battery is at 1%, but the display screen is stuck showing 100% to everyone else.
Yeah, that's so accurate.
And the world, your employer, your family, your friends, they keep asking you to open heavy battery-draining apps like commute to the office, attend the parent-teacher conference, be charming and witty at a dinner party.
And you attempt to run those programs, but your system simply doesn't have the power.
Exactly. And when you inevitably shut down or you have to cancel plans, everyone judges you because, according to the screen they see, your battery looked perfectly full.
That analogy captures the cognitive and emotional drain with remarkable precision. I mean, it requires an immense allocation of neurological bandwidth to suppress the natural evolutionary responses to severe pain.
Right, because your body wants to react.
It does. A patient has to consciously suppress the urge to grimace, the instinct to limp, or the reflex to guard the painful area.
All while simultaneously trying to, track a complex conversation or execute a demanding work task.
Yes, the brain is quite literally multitasking at its absolute limit.
Yeah.
And over time, the sheer effort required to sustain that facade of wellness becomes more exhausting than the underlying pain itself.
And what's the result of that?
Profound social withdrawal. I mean, patients simply stop attending events because the performance is just too costly. They isolate to conserve whatever minimal energy they have left.
But the pressure of that social performance, it must go beyond just emotional exhaustion. I mean, if a person is constantly smiling through agony, terrified of judgment, suppressing every instinct to show their pain, That level of continuous psychological masking has to physically alter the body.
Oh, it absolutely does.
Like the mask itself must become a physiological weapon against the patient's own nervous system.
It does. The stress of constant invalidation and that monumental effort of concealment, it physically alters neurobiology.
How so?
Well, when a patient is perpetually, terrified of being judged, anxious about an unpredictable pain flare-up occurring in public, their autonomic nervous system is locked in a sympathetic dominant state.
The classic fight or flight response.
Exactly. The body is flooded with cortisol and adrenaline. And because this state is chronic, the parasympathetic nervous system, which is the rest and digest phase.
The phase where you actually recover.
Right. That phase is rarely engaged. So this state of prolonged physiological arousal increases resting muscle tension, it drives up systemic inflammation, and it demonstrably lowers the individual's pain threshold.
Wait, so by trying to hide the pain to appease society, the patient inadvertently amplifies the biological signals of the pain itself.
Yes, they are making the pain physically worse by trying to hide it.
Which makes the discussion around pain behaviors in the medical literature so complicated. I mean, the sources address this concept of secondary gain, which is honestly often weaponized against patients.
Very heavily weaponized.
It's crucial we unpack what that actually is versus what the vast majority of patients are doing when they are just desperately trying to be understood.
Right. The concept of secondary gain requires extremely careful, nuanced handling. The clinical literature does acknowledge a subset of patients who engage in exaggerated pain behaviors.
Like vocalizing loudly or walking with an exaggerated limp.
Yeah. Or continuously seeking highly visible assistance. In these rare cases, the illness provides a psychosocial benefit or secondary gain. So that could be obtaining attention, securing financial compensation, or achieving exemption from undesirable duties.
Right.
However, and this is the crucial part, we must emphasize that this is a statistically minimal subset.
Right. But the medical system treats it like it's everyone.
That's the profound danger. The medical system often misconstrues the vast majority of legitimate patients as seeking secondary gain. In reality, these patients are simply desperate to be believed.
They're not malingering.
No, they are attempting to visually demonstrate an invisible internal agony because verbal communication has entirely failed to secure them the validation and care they require.
They are turning up the external volume because the internal alarm is being completely ignored by the very people supposed to help them.
Exactly.
And that shift from the social misunderstanding of pain to the stark biological reality of it, that is where the science and our deep dive gets truly fascinating.
Yes, the cellular level.
Right. If we step away from society's judgment and look at the cellular level, we have to examine what the sources describe as the electrical storm.
The electrical storm. To comprehend this, we have to delineate the fundamental difference between acute and chronic pain at the level of the peripheral nervous system.
Okay, break that down for us.
So, acute pain is typically nociceptive. Nociceptors are high-threshold sensory receptors distributed throughout the skin, muscles, joints, and viscera. They are the body's danger sensors.
Okay.
If you inadvertently touch a hot stove, the nociceptors are activated. A chemical messenger signal crosses the synaptic cleft, the electrical impulse shoots up the peripheral nerve to the spinal cord and then to the brain, prompting you to reflexively pull your hand away.
So that is a perfectly functioning, evolutionarily adaptive system.
Right, it prevents massive tissue destruction.
It's a localized alarm system directly proportional to an actual physical threat.
Exactly. However, in the context of chronic pain, specifically neuropathic and nociplastic pain, that protective mechanism completely breaks down.
Okay, so neuropathic pain. That arises as a direct consequence of a lesion or disease affecting the somatosensory system, right?
Right. This could be diabetic neuropathy, where high blood sugar damages the nerve fibers, or physical trauma like an amputation.
And nociplastic pain.
Nociplastic pain is a newer, even more complex classification. It arises from altered nociception, so abnormal processing of pain signals, despite no clear evidence of actual or threatened tissue damage.
Wait, so no actual damage?
No evidence of it causing activation of peripheral nociceptors, and no evidence for disease or lesion of the somatosensory system. The nervous system itself has fundamentally altered its own baseline sensitivity.
And the sources detail the specific genesis of this chaos, starting with a phenomenon called the injury discharge.
Yes, the injury discharge.
When a peripheral nerve experiences trauma, it doesn't just send a standard hot stove warning signal, does it? It initiates an event that changes the entire trajectory of the nervous system.
It's a catastrophic cellular event. Upon injury, the peripheral nerve fires an afferent barrage, which is an intensely high-frequency, massive burst of neural activity traveling toward the central nervous system.
And how is that different from a normal pain signal?
It is morphologically distinct from a normal nociceptive response. It differs wildly in its peak frequency, the prolonged duration of the firing, and the sheer volume of neural units participating in the signal. It simply overwhelms the normal carrying capacity of the nerve pathway.
It's essentially a power surge that blows out the delicate circuitry in the spinal cord.
That's a great way to put it.
And the aftermath of that surge leaves the nerves permanently altered, leading to what the literature calls ectopic excitability.
Ectopic excitability is where the biological reality becomes truly terrifying.
Why terrifying?
Well, following nerve transection or severe injury, as the nerve futilely attempts to regenerate, it undergoes structural changes. It may grow multiple disorganized sprouts or form neuromas.
What's a neuroma?
They are dense, tangled masses of unorganized nerve tissue and Schwann cells. And these neuromas and sprouts are electrophysiologically unstable.
Meaning what, exactly?
Due to alterations in the expression and distribution of sodium and potassium ion channels along the nerve membrane, these structures begin to depolarize and fire spontaneously. They generate action potentials in the absolute absence of any external mechanical, thermal, or chemical stimulus.
Wow. So the wire has been cut, and the frayed, exposed ends are just sparking randomly in the dark. The patient isn't touching anything hot, no one is pressing on the limb, there's no physical trauma occurring in that moment, but the brain is receiving high-fidelity signals that the body is being electrocuted or stabbed.
That is the biological truth of their experience. And those spontaneous signals do not occur in a vacuum.
Where do they go?
They travel proximally up to the dorsal horn of the spinal cord. The dorsal horn is the critical relay station where peripheral sensory input is processed before ascending to the brain. This continuous, relentless barrage of ectopic firing initiates what we call central sensitization. The architecture of the spinal cord literally changes.
Structural reorganization, the sources call it.
Exactly. In a healthy nervous system, the nerves that transmit pain, the A delta and C nociceptive fibers, they terminate in the superficial laminae of the dorsal horn.
Okay, so pain signals go to the superficial layer.
Right. Conversely, the low threshold, beta sensory fibers, which are the nerves responsible for transmitting non-painful information like the light touch of a feather, the texture of clothing, or ambient temperature, they terminate in the deeper laminae.
So the circuits are kept strictly segregated.
Very segregated.
But the relentless power surge of the injury discharge breaks down that segregation, doesn't it?
Yes, it does.
The constant bombardment of pain signals creates an environment where those low-threshold, non-pain sensory fibers actually begin to sprout new growth. They physically extend up into the superficial layers of the dorsal horn, the territory meant exclusively for high-threat pain signals.
They literally crosswire the circuits.
They crosswire the circuits. That is wild.
And that anatomical crosswiring is the precise mechanism behind two of the most baffling and debilitating hallmark symptoms of chronic nociplastic and neuropathic pain.
Right.
Allodynia and hyperalgesia.
Break those down for us.
Sure. Allodynia occurs when a completely innocuous, non-noxious stimulus, such as the gentle brush of a cotton bedsheet against the skin or the feeling of a light breeze, elicits a severe pain response.
From a breeze.
From a breeze. The physical input at the skin level is merely touch, but because the beta fibers have cross-wired into the nociceptive pathways in the spinal cord, the signal arriving at the brain translates the input as massive tissue damage.
That's allodynia. And hyperalgesia.
Hyperalgesia, similarly, is an exaggerated prolonged pain response to a mildly painful stimulus. A simple pinprick is amplified into the sensation of a deep traumatic laceration.
The physiotherapy literature provides a highly accessible analogy for patients trying to understand this cross-wiring. They describe it as monkeys with microphones.
Yes, it is a vivid and accurate visualization for patient education. If you conceptualize the sensory receptors in your nervous system as small monkeys holding microphones, their job is to report environmental data back to the brain.
Right.
In a state of central sensitization, the monkeys are trapped in a state of high alert and panic. They have turned the gain dials on their microphones all the way up to maximum sensitivity.
So even the quietest sound is deafening.
Consequently, even the slightest whisper of a physical sensation, a drop of water, a change in barometric pressure, is captured, wildly distorted, and broadcast as a screaming, deafening alarm. The brain's internal amplifier is permanently blown out.
And it is not merely a structural rewiring. There is a dense chemical soup orchestrating this entire storm. The role of glial cells completely changes how we understand the nervous system's immune response to pain.
The neurochemical cascade is highly complex. During central sensitization, the continuous neural firing causes the massive release of excitatory neurotransmitters and neuromodulators, predominantly glutamate and substance P.
Right, into the synaptic clefts of the dorsal horn.
Yes. And these bind to specific receptors, notably the NMDA receptors. When NMDA receptors are activated, which normally requires a strong, sustained depolarization just to remove a magnesium ion block, it is akin to opening the floodgates.
Calcium rushes in, right.
Exactly. Calcium rushes into the postsynaptic neuron, triggering intracellular pathways that drastically amplify the excitability of the pain-transmitting nerves. Furthermore, we see profound glial cell activation.
The glial cells, what do they normally do?
Glial cells, such as microglia and astrocytes, function as the resident immune cells of the central nervous system. Under chronic pain conditions, they shift from a quiescent, supportive role into an active, defensive state.
So they start fighting?
Yes, they begin releasing a torrent of pro-inflammatory cytokines, chemokines, and nerve growth factors. This inflammatory soup bathes the neurons, further lowering their firing thresholds and cementing the state of hypersensitivity.
So the system meant to protect the nerves ends up suffocating them in inflammation. And perhaps the most insidious mechanism mentioned in the sources is phenotypic switching. This is where the biological failsafes don't just stop working, they actively turn against the patient.
Phenotypic switching is a devastating biological betrayal. A healthy central nervous system possesses powerful descending inhibitory pathways originating from the brainstem, as well as local inhibitory interneurons within the spinal cord.
So these are the brakes.
Yes, these systems utilize neurotransmitters like GABA and glycine to inhibit or dampen ascending pain signals. They function as the essential brakes on the sensory vehicle.
Right.
However, in the altered neurochemical environment of central sensitization, some of these critical GABAergic interneurons undergo a phenotypic switch. Due to changes in intracellular chloride ion concentrations, the release of GABA, which normally hyperpolarizes and quiets the target neuron, suddenly depolarizes and excites it.
Wait, so the inhibitory neurotransmitter becomes an excitatory one?
The brakes entirely fail, and worse, pressing the brake pedals suddenly accelerates the vehicle toward extreme pain.
So if we synthesize all of this, the ectopic firing, the structural cross-wiring of the dorsal horn, the inflammatory glial soup, and the phenotypic switching of the inhibitory brakes, we arrive at a profound conclusion.
Which is?
The original injury may be long gone, the tissue has entirely healed, there is no ongoing physical damage occurring in the periphery, but the spinal cord and the brain are trapped in a self-sustaining loop of generated pain.
Yes.
And yet there is a pervasive bias in society that if the tissue is healed, the pain is just psychological, like it's all in the patient's head.
We must violently dismantle the notion that central sensitization implies the pain is in the patient's head, in the dismissive psychiatric sense of the phrase.
The psychological literature embedded within our sources states this unequivocally.
Quote, "All pain is real. There is no such thing as imaginary pain." The fact that the pain is being generated by altered neural networks, structural reorganization, and neurochemical shifts in the central nervous system does not diminish the reality of the patient's suffering. I mean, the brain is the organ responsible for generating every single physical sensation we experience. If the brain's sensory map is inflamed and misfiring, the pain is as biologically real as a freshly broken bone.
It's perfectly analogous to a faulty home security system.
Right.
Imagine you install a highly advanced, state-of-the-art alarm system to protect your house. But over the course of several months, the motion sensors degrade and become incredibly hypersensitive.
Like the monkeys with the microphones.
Exactly. Eventually, a piece of dust floats across the living room or a cloud shadow passes over the window, and the sensors interpret that minute change as a catastrophic breach. The system triggers a full-blown, ear-shattering siren, automatically dispatching an armed police response to your front door.
It's chaos.
The police showing up with guns drawn, that adrenaline, that chaos, that disruption that represents the pain, that physiological response is incredibly real, and it is happening in real time, even if the burglar representing the actual tissue damage doesn't exist.
Right.
You cannot tell the terrified homeowner, oh, the siren is all in your head. The siren is actively destroying their quality of life.
That analogy perfectly encapsulates the pathology. And if we require the ultimate, undeniable proof of this central electrical storm, we only have to examine the phenomenon of phantom limb pain.
Right, because the limb isn't there.
Exactly. A patient undergoes a surgical amputation. The physical tissue of the leg is entirely removed. It is biologically gone. Yet the patient experiences agonizing, crushing, burning pain in the foot that no longer exists
How is that possible?
because the peripheral nerve was severed, triggering the massive injury discharge. The dorsal horn reorganized, and the somatosensory cortex in the brain, the map of the leg, remains intact but is deprived of normal input. The central nervous system begins firing spontaneously within that map. The pain is undeniably real, generated entirely by the altered architecture of the central nervous system, completely independent of peripheral tissue.
If the central nervous system is functioning like a security system, screaming 24 hours a day, 7 days a week, flooding the entire biological system with high alert danger signals, the psychological dam is inevitably going to break.
It has to.
You cannot separate that persistent electrical storm in the spinal cord from a person's mental health. The physical reality directly causes psychological trauma, and as the sources show, psychological trauma feeds right back into the physical pain. It's an intersecting storm.
The relationship between chronic pain and mental health is profoundly bidirectional. You cannot artificially bifurcate the mind and the body. They operate as a single, unified neurobiological system.
Right.
When a patient is trapped in chronic pain, their body is locked in that sympathetic dominant fight or flight response we mentioned. The physiological stress response is perpetually activated. Because the body never achieves the parasympathetic recuperation phase, neurochemistry fundamentally alters.
So prolonged exposure to stress hormones like cortisol impacts the hippocampus and the prefrontal cortex, right?
Yes, areas critical for mood regulation and cognitive function.
The statistical evidence from the umbrella review in our sources is staggering on this. They analyzed chronic pain prevalence across massive cohorts of individuals diagnosed with severe mental health disorders, and the overlap is undeniable.
The numbers are alarming.
The prevalence of chronic pain is 23.7% in people diagnosed with bipolar disorder. It sits at 29.5% for individuals with schizophrenia. It jumps significantly to 66.9% in people with ADHD. It ranges between 53.8% and 65% for those suffering from major depressive disorder.
And then there's the PTSD data.
Right. Between 88% and 96% of people diagnosed with PTSD suffer from chronic pain.
96%. That figure demands a pause. I mean, if an individual has endured severe psychological trauma resulting in PTSD, it is almost a statistical certainty that they are also living with chronic physical pain.
That is just, it's unbelievable.
It is. This immense comorbidity rate highlights the shared biology underlying both conditions. The biological mechanisms driving severe depression, anxiety, and trauma are heavily reliant on the same neurochemical pathways.
The ones involving serotonin, norepinephrine, and dopamine.
Exactly. The same pathways that the central nervous system utilizes to modulate pain. The physiological language of emotional suffering and the physiological language of tissue damage are, in many ways, identical.
But when a patient presents with a severe mental illness, or SMI, and they also have physical pain, they face an incredibly dangerous phenomenon known as diagnostic overshadowing.
This happens all the time.
The medical system frequently fails to navigate this shared biology.
Diagnostic overshadowing is a pervasive and dangerous systemic bias. It occurs when a patient with a documented psychiatric history, such as schizophrenia, bipolar disorder, or severe depression, presents to a medical professional with legitimate, severe physical pain.
And what does the doctor do?
Due to systemic stigma and a lack of integrated care, the clinician subconsciously or consciously attributes the physical symptom entirely to the psychiatric condition.
So if a patient with major depressive disorder presents with severe lower back pain,
the clinician may simply chart it as a somatic manifestation of their depression. The physical pain is entirely overshadowed by the mental health diagnosis. The underlying physical pathology goes uninvestigated, and the patient is left untreated and deeply invalidated.
imagine a schizophrenic patient experiencing a legitimate neuropathic flare-up or even a structural injury, and the emergency room doctor just assumes their distress is part of an active psychotic episode.
The physical suffering is completely erased.
This constant erasure and relentless pain inevitably leads to a state of pain catastrophizing, which is a term that requires careful definition so it isn't used to victim blame.
Right. It is vital to clarify that pain catastrophizing is not a conscious choice by the patient to exaggerate or manipulate. In the clinical literature, it describes a specific psychological state characterized by a profound feeling of helplessness, a persistent inability to stop ruminating on the pain, and an extreme magnification of the threat value associated with the pain sensation.
Which seems like a pretty natural reaction.
It is a deeply natural human response when subjected to relentless, inescapable suffering. Physiologically, a state of high negative emotions such as fear, anxiety, or catastrophizing directly amplifies the physical experience of pain.
Because of the amygdala.
Yes, the amygdala, the brain's emotional processing center, is intimately connected to the descending pain modulatory pathways. When a patient is highly distressed, the amygdala essentially sends signals that turn up the volume knob on the pain signals descending into the spinal cord. Emotional distress physically manufactures higher levels of nociceptive input.
So the emotional distress amplifies the physical signal, which increases the pain, which increases the distress. It is an inescapable physiological loop.
Parable loop.
And that loop creates a tragic reality of unmet needs. The sources indicate that the lifetime prevalence of suicide attempts in populations living with chronic pain ranges from 5% to 14%.
The pain-related risks are overwhelming.
Sleep architecture is continuously disrupted, leading to profound neurotoxic fatigue. Patients experience a high perceived sense of total disability. Ultimately, this cultivates a desperate, overwhelming need for what the clinical literature bluntly calls pain escape.
Pain escape. When a human being is deprived of restorative sleep for months or years, when every physical movement is accompanied by agonizing electrical signals, and when their subjective experience is continuously invalidated by their medical providers and their social support networks, the desire for pain escape becomes a primal imperative for survival.
They just need it to stop.
Exactly.
Hmm.
The patient is not necessarily exhibiting a primary desire to end their life. Rather, they are utterly desperate to end the relentless sensory assault, and society has failed to provide them with any viable medical or psychological tools to achieve that relief.
When you look at the ADHD data in these sources, it fundamentally challenges how we view pain intervention. The researchers found that in a cohort where 76.6% experienced chronic pain, treating the underlying ADHD with central nervous system stimulants, which are medications primarily designed to improve executive function and focus, actually reduced the prevalence of chronic widespread pain from 42% all the way down to 16.7%.
That finding is paradigm shifting.
Stimulants dropped widespread physical pain prevalence by more than half.
It perfectly illustrates the fallacy of treating the mind and the body as separate entities. By manipulating the neurochemistry of the brain, specifically by altering dopamine and norepinephrine reuptake pathways to treat the cognitive symptoms of ADHD, the medical intervention directly, profoundly altered the patient's physical perception of somatic pain.
That's incredible.
It proves that neurochemical modulation of psychiatric symptoms can simultaneously act as a potent analgesic for nociplastic pain.
But when the escape is nowhere to be found, when the sleep deprivation reaches a critical mass and a massive pain flare-up occurs, say at 2 a.m. on a Friday night, patients inevitably seek immediate, desperate help.
Naturally.
But the place they almost universally end up is an environment fundamentally designed to fail them. We have to analyze the systemic mechanics of the emergency room and what the sources label the triage trap.
The triage trap.
Yeah.
The emergency department or casualty department is the vital safety net of the global healthcare ecosystem. Interestingly, despite the ER being designed for acute trauma, pain is the single most common presenting symptom in emergency departments worldwide.
Right. People want emergency care because they are suffering from intolerable nociceptive or neuropathic input.
But the ER operates strictly on an acute medical model. The entire infrastructure is built to manage car crashes, myocardial infarctions, and massive hemorrhages. It is designed to ensure you do not die within the next 60 minutes.
And that acute mandate creates the triage trap. This is a phenomenon entirely unique to emergency medicine, where patients present with severe, agonizing 10 out of 10 pain originating from conditions that are functionally non-serious in the immediate medical sense, meaning the pathology won't kill the patient or cause loss of limb that night.
Right. The ER's imperative is rapid triage. Stabilize the patient, definitively rule out catastrophic life threats, and rapidly discharge them to clear the bed for the next incoming trauma.
Right. Move them along.
The physical space, the staffing models, and the pharmacological protocols are simply not equipped, nor were they ever designed to manage complex, chronic, neuroinflammatory diseases.
The friction between the patient's need and the system's design is absolute. Walk through what actually happens during one of these visits.
Well, the patient waits 6 hours under harsh fluorescent lights, which, by the way, further agitates a sensitized nervous system.
Right. The monkeys with microphones?
Exactly. They wait to finally see the ER doctor. The doctor runs the standard acute playbook. They order a CT scan or an X-ray, looking for the ruptured appendix, the internal bleeding, the acute nociceptive driver.
And when the scans come back clear?
The doctor concludes the assessment. They essentially say, your vitals are stable, you are not dying. Follow up with your primary care provider next week.
And they just send them home.
The patient is discharged, perhaps given a small script for an NSAA or a few days of weak medication that barely scratches the surface of central sensitization.
And that interaction highlights a profound systemic disconnect. By the metrics of emergency medicine, that entire encounter is classified as a success.
A huge success.
The physician successfully stabilized the patient, correctly ruled out catastrophic emergencies, utilized resources efficiently, and safely discharged the individual. The system performed exactly as designed.
But from the perspective of the patient, the encounter is a catastrophic, devastating failure. They expended massive amounts of physical and emotional energy to get to the hospital, endured an environment hostile to hypersensitive nerves, and were sent home still trapped in absolute agony.
Feeling entirely dismissed, gaslit, and untreated.
Yes.
And the sources heavily emphasize that this systemic failure is not distributed equally across the population. There are massive, documented disparities in how emergency pain care is administered.
The disparities in emergency analgesia are deeply troubling and extensively documented. Substantial heterogeneity exists in pain management based on demographics.
Like racial and ethnic disparities.
Yes, marginalized racial and ethnic groups, specifically Black and Hispanic patients in the United States healthcare context, face significant systemic disparities in receiving adequate pain relief.
What does the data show?
The empirical data repeatedly demonstrates that these populations are prescribed lower doses of pain medication, they wait statistically longer to receive any form of analgesia, and their self-reported pain scores are systematically underestimated by clinicians when compared to white patients presenting with identical symptoms and pathology.
The physiological toll of that health inequity is one of the most vital points in the research. The social environment actually gets under the skin. It isn't just a societal failure regarding bias. The racism and marginalization literally manufactured the biological conditions for worse pain.
That is correct. The field of neuroimmunology provides compelling evidence that chronic social stressors, the grinding daily psychological toll of facing systemic injustice, racism, microaggressions, and socioeconomic marginalization, directly alter an individual's neuroimmunological baseline.
How does that work?
Chronic exposure to these stressors increases the expression of pro-inflammatory genes within the immune system. This results in persistently higher circulating levels of pro-inflammatory cytokines in the bloodstream.
Which are the same markers driving the pain.
Yes. These are the exact same immune markers that play a pivotal role in driving widespread persistent pain, accelerating neuroinflammation, and sensitizing the dorsal horn.
So the societal injustice manufactures the systemic inflammation, which manufactures the generalized physical pain. And then when those marginalized patients seek emergency care for the pain society helped create, the medical system minimizes their suffering due to systemic bias.
It is a devastating double jeopardy.
It's infuriating.
And it leads to a profound, often irreparable erosion of trust in the healthcare system. We frequently observe these patients leaving the emergency department against medical advice, AMA, because they recognize the futility of the interaction.
Or they retreat into a completely passive, desperate role. They stop seeking care entirely, simply bracing themselves for the next agonizing flare-up in isolation, feeling completely helpless against a system that refuses to see them.
But the acute care model itself is philosophically opposed to chronic pain management, specifically in how medication is deployed.
Right. The sources contrast the reverse WHO ladder with the stepped approach.
The pharmacological philosophies are in direct, unyielding opposition. When an ER physician treats acute, severe trauma pain, for example, a compound fracture of the femur, they instinctively utilize what is known as the reverse WHO analgesic ladder.
And what does that entail?
The protocol dictates starting at the absolute top of the intervention scale. They administer small, frequent doses of highly potent intravenous opioids, like morphine or fentanyl, to immediately seize control of the severe pain and stabilize the patient's autonomic nervous system.
Hit it hard and fast.
Yes. As the acute tissue damage begins to heal over the following days, the pharmacological intervention is stepped down to weaker oral medications.
You hit the pain hard and fast with the heaviest tools available, then retreat as the body recovers.
Exactly. But the globally accepted medical guidelines for chronic, non-cancer pain mandate the exact opposite strategy, the stepped approach. This protocol insists that clinicians must start at the absolute bottom rung of the pharmacological ladder. They must initiate treatment with non-opioid medications, such as acetaminophen, NSAIDs, SNRIs or gabapentinoids, regardless of how intense the patient's current subjective pain score is.
So even if they're at a 10 out of 10, they start at the bottom.
Yes, the clinician is only permitted to step up to stronger, more complex medications if the baseline treatments categorically fail after a prolonged trial period.
Okay, so when a chronic pain patient enters the ER in the midst of a 10 out of 10 flare-up, they are desperately seeking a reverse WHO ladder immediate rescue intervention.
Right.
But they are presenting with a disease state that medically, legally, and philosophically dictates a slow, cautious, bottom-up stepped approach.
The ER is simply the wrong tool for the disease.
So if the ER isn't the solution, and the societal demand for a performance of wellness is physically draining the patient's battery, where does the agency lie? How does a patient avoid the triage trap and reclaim their life?
This brings us to the final section of our research, which focuses heavily on shifting paradigms and establishing fierce, unapologetic social boundaries.
Right. The primary and often most psychologically difficult step in reclaiming agency requires a fundamental shift in expectations for both the patient and the healthcare provider.
Exactly. The goal must definitively shift from eradicating the pain to controlling it. Chronic pain, much like asthma, type 1 diabetes, or rheumatoid arthritis, is a condition to be managed over a lifespan, not a transient infection to be cured with a simple antibiotic.
Management, not cure.
The clinical objective becomes functional and emotional restoration, optimizing the patient's quality of life, mobility, and psychological well-being, while acknowledging that the pain signal will likely remain present.
That shift from eradication to management relies heavily on energy conservation. And we have to talk about social boundaries because earlier we established that the performance of pretending to be fine is literally destroying patients' nervous system.
Yes, the 1% battery analogy.
Right. The sources provide very specific, highly actionable communication strategies for boundary setting.
The literature is definitive on this. Say what you mean with absolute clarity and never apologize for the biological realities of your health.
Which is hard because societal conditioning, particularly for women, heavily encourages apologizing when an illness inconveniences others or disrupts social norms.
It does. But the clinical advice explicitly warns against minimizing language or framing boundaries as requests for permission. Using phrases like, "I'm really sorry, but I think my back is hurting, so maybe I should sit down for a minute if that's okay with everyone," is highly counterproductive.
Because it frames your critical biological need, the need to stop aggravating an inflamed nervous system, as a burden on the group, and it gives the group power to validate or invalidate the need.
Precisely. When a patient apologizes, they linguistically minimize their own physical reality and assume the emotional labor of managing other people's discomfort with illness.
So what's the recommended approach?
It should be firm, declarative, and informative. My pain is flaring up, so I'm going to sit down now. The sentence ends there. There is no apology, no justification, and no request for permission.
Just a statement of fact.
The patient is simply stating an objective fact about their body's current operational capacity and the necessary action they are taking to manage it. This preserves precious cognitive bandwidth.
But boundary setting isn't just about pushing demands away. It is also about cultivating the correct type of connection. The sources emphasize that positive social connectivity is a biological imperative.
Oh, absolutely. It demonstrably reduces blood pressure, lowers resting heart rate, and decreases circulating stress hormones. Conversely, profound isolation triples the statistical odds of developing severe depression.
So connection is vital, but the nuance lies in the quality and type of social support. The clinical literature carefully distinguishes between two highly unhelpful, though common, types of social responses from partners or family members: solicitous and punishing responses.
Yes, solicitous responses occur when a loved one becomes hyperprotective. They constantly ask the patient for pain ratings, they physically take over all household tasks, and they actively encourage the patient to remain in bed and avoid all exertion.
Which sounds nice, but
While this behavior originates from genuine care, empirical data shows that solicitous responses actually increase long-term patient disability, foster severe deconditioning, and firmly reinforce the sick role psychology.
they essentially kill the patient's independence with kindness.
That's one way to put it.
And on the extreme other end is the punishing response.
Punishing responses are overtly toxic. This occurs when the partner or family member expresses visible frustration, rolls their eyes, becomes angry at cancellations, or actively ignores the patient's verbalizations of pain.
And what does that do to the patient?
This hostile environment forces the patient to either suppress their suffering entirely, driving up internal stress, or dramatically amplify their visible pain behaviors simply to force an acknowledgement of their existence.
So what is the middle ground? What do patients functionally require?
Validating, empowering support. The optimal response from a partner is, I see that you are experiencing severe pain. I completely believe your experience. What specific tools do you need to manage this right now? And how can I facilitate your management plan without taking away your autonomy?
That is such a powerful response. And one of the most critical tools in that management plan, discussed extensively in the sources, is the concept of pacing.
Pacing is essential.
To conceptualize pacing, think of it as budgeting a strictly fixed, non-negotiable income.
Pacing is a mandatory survival skill. It requires meticulously breaking down daily tasks into smaller, manageable increments and proactively taking scheduled, disciplined rest breaks long before the pain reaches a threshold that forces activity cessation.
But there's a barrier to that, right?
A massive one. However, to effectively implement pacing, the patient must confront and overcome a massive psychological barrier, kinesiophobia.
Which translates to the profound fear of movement.
Yes. When the simple act of standing up or walking generates searing pain signals, the brain's baseline evolutionary instinct is to freeze and avoid the movement entirely. But in chronic pain, inactivity creates a catastrophic downward spiral.
The deconditioning.
Right. Muscle mass degrades, joints become rigid, cardiovascular endurance plummets, systemic fatigue increases, and the resulting deconditioning actually amplifies the baseline pain.
But that creates a massive paradox for the patient. If movement causes immediate agony, the brain screams at them to stop. Overcoming that must require a complete psychological rewiring regarding what the pain signal actually means.
It requires a profound cognitive restructuring, heavily focused on understanding the difference between hurt versus harm.
Hurt versus harm.
This is arguably the most crucial mental shift in chronic pain rehabilitation. Patients must be taught that just because they are hurting, meaning their nervous system is broadcasting an incredibly unpleasant high-volume alarm signal, it does not mean their physical body is actively being harmed, damaged, or destroyed by the movement.
Because of central sensitization, the alarm system is faulty. It is ringing without a fire.
Exactly. Recognizing that the pain is a false alarm regarding tissue damage is the only way to break the fear avoidance cycle and gradually reintroduce movement.
Which introduces a word that many chronic pain patients initially despise: acceptance.
Oh, yes.
When a patient first hears that word in a clinical setting, it sounds like forced resignation. It sounds like a doctor telling them, medical science has given up on you, your life is permanently ruined, and you just have to accept this misery.
That is a deeply understandable resistance. But it stems from a misinterpretation of the clinical term. Within the framework of evidence-based coping skills training, such as cognitive behavioral therapy, CBT, or mindfulness-based stress reduction, MBSR, acceptance does not equate to defeat or resignation.
What does it mean then?
Acceptance is the active, clear-eyed acknowledgement of the current biological reality. It is the conscious decision to stop expending massive amounts of precious, limited energy fighting an unwinnable war against the existence of the pain itself.
Because fighting it drains the battery even faster.
Right. The empirical studies demonstrate that patients who achieve a state of acceptance, who cease their relentless, exhausting search for a miraculous total cure, and instead focus on what variables they can control, report significantly lower overall pain intensity, decreased rates of clinical depression, and better long-term functional outcomes.
So acceptance is the strategic reallocation of energy from a futile battle toward engaging in meaningful, modified life activities alongside the pain. And that requires navigating complex emotional terrain, particularly when enforcing those boundaries with an employer or even a spouse who remains stubbornly emotionally attached to the old, healthy version of the patient, the person who used to routinely work 60 hours a week and run half marathons on the weekend.
It is an ongoing process of grief and negotiation. It requires challenging the deeply ingrained societal assumption that a productive, meaningful, or joyful life is fundamentally impossible if pain is present.
Which means mourning the loss of the pre-illness identity.
The patient and their loved ones must mourn that loss while creatively and aggressively modifying their environment for their current biological reality. If a patient loved the identity of being an avid hiker but physically cannot navigate the trails anymore, the management approach asks, can you drive to a scenic overlook and engage in nature photography?
Finding alternatives.
The patient must communicate clearly with employers regarding necessary, legally protected accommodations without guilt. They must educate their support network regarding the biological reality of the electrical storm in their nervous system, shifting the blame from a lack of willpower to a recognized neurological state. Ultimately, it is the process of reclaiming self-efficacy in a body that feels entirely out of control.
Well, we have journeyed through an immense amount of complex territory today in this deep dive. We started by validating the invisible, exhausting burden of the looking fine paradox, the daily $500 billion societal performance of pretending the battery is full while the system shuts down.
Yeah.
We unpacked the stark biological reality of the electrical storm in the spinal cord, demonstrating how ectopic firing, glial cell inflammation, and phenotypic crosswiring prove that this suffering is never just imaginary.
The science is clear on that.
And we analyzed the systemic failure of the triage trap, acknowledging that the acute tools of the ER are fundamentally misaligned with the chronic reality of a sensitized nervous system. And finally, we laid out the necessary blueprint for reclaiming agency, setting unapologetic boundaries, meticulously budgeting energy, and recognizing the difference between a hurting nerve and a harmed body.
It is a staggering amount of pathology to manage, but achieving a deep mechanistic understanding of these biological systems is the absolute first step toward reclaiming power over them. The pain loses some of its terror when the mechanisms are demystified. I want to leave the audience with one final, deeply counterintuitive concept derived from the physiological research we reviewed today.
Please share it.
When we examine the paradox of human behavior in relation to chronic illness, we find a brutal irony. The exact physiological and psychological responses that are perfectly healthy, highly adaptive, and evolutionarily demanded for acute pain, such as resting completely, guarding the injured tissue, avoiding all painful movement, and waiting passively for the body to heal itself, become the precise mechanisms that fuel, deepen, and worsen chronic pain.
Wow.
To truly reclaim function from a sensitized nervous system, a patient is forced to do the unthinkable. They must intentionally fight their own evolutionary survival instincts. They must engage in physical movement when their brain's alarm system is screaming at them to freeze. They must actively engage with their environment when their biology is begging them to isolate and hide. It is a profound test of human endurance.
It really is.
And it forces us to ask a broader question, even beyond the realm of physical pain. What else in your life are you currently avoiding under the guise of protecting yourself that is actually the very thing keeping you trapped?
That is a staggering reality to confront. If you are listening to this right now and you are the one living with that invisible fire alarm constantly blaring, we hope this deep dive has provided you with the scientific vocabulary to explain your reality, the clarity to understand your own nervous system, and most importantly, the profound validation you deserve.
You are definitely not alone.
The pain you carry may be invisible to the room around you, but you are seen, you are heard, and the science proves that your experience is undeniably real. Take care of yourselves.